Previous book, they were separate. We separated male and female reproductive chapters. Now they're mixed in. So I'm going to start off by just running through a lot of the female reproductive because my lecture and my tests are set up that way. We cover female because it has a lot more information in it first. So I'll quiz you on a lot of the female first. We finish off next week the rest of female and all of male. And then your comprehensive test for reproductive is both male and female. Make sense? Okay. So, chapter 57, diagnostic and therapeutic procedures for Repro disorders. And it starts off by saying, right, screening tests can be used to aid early identification of cancers, STIs, certain reproductive disorders. A lot of these are for breast, testicular, prostate, cervical. Right? Clients that are at high risk should come in earlier. If needed and things are normal, what will be the next follow-up step? They see like something weird, they will take a biopsy, okay, to be able to test for the abnormality. So let's start with the first one. On page 419, you will see pelvic and bimanual exam. An examination performed by a provider to examine the external and internal reproductive organ. The client is placed in a lithotomy position. So covering pelvic exam. And we will do here as well Papa Nicolau, I guess they spell it, test, might, O or U might be in the wrong place. And a pap, which is also currently known, right, or most people know it as a pap smear. Pelvic exams usually, not always, but most of the time probably go hand in hand with a pap smear. Okay? Now don't confuse both because a lot of times people go like, oh, I'm going to give them a pelvic exam, or I'm going to get a pelvic exam, and the two are assumed because they're just about always done together. But a pelvic exam is a pelvic exam. Pap smear is a pap smear, okay? Pelvic exam is the provider with his hands, right, his or her hands, will palpate, okay, and feel around your pelvis in your pelvic exam. Additionally, they may feel the upper portion here, right, of your pelvis, and can manually insert fingers into the vagina to be able to palpate the structure as well, okay? So this is mainly just a felt exam. They're trying to palpate for any masses, abnormalities, or anything that may be forming. A lot of this is palpation. It's a pelvic exam by a doctor. Okay? Now, a pap smear, we will go into soon. So let's do pelvic, right? Prior to examination, so it says internal, so the provider will examine the internal and external organs. The client is placed in a lithotomy position. Are we all aware of what position that is? Lithotomy, basically, right? Like when they're about to give birth, so you get with your legs up on the stands. Okay? So you need to know what position they're in. Prior to examination, the provider should be comfortable. The provider can inspect and palpate external genitalia for any findings. During the internal, the provider inserts a warm, lubricated speculum into the client's vagina to examine the cervix. The provider can also perform cervical screening, pap smear, and HPV testing, and cervical cultures. Okay, a bimanual exam is an internal exam in which the provider inserts two lubricated gloved fingers into the vagina and traps the reproductive structure between the opposite hand on the abdomen and palpates the client's internal reproductive structures. Are we all following so far? This is what we're talking about. Palpation for internal, external organs. Okay? What do we teach the client? And for the client to schedule this examination 6 to 10 days after their last menstrual cycle, to present. Inform the client to avoid prior to exam, you need to know this. Void, right? They need to urinate before the exam, empty their bladder. During internal examination, inform the class to take deep breaths and relax the muscles and bear down while the speculum is being inserted. So the important thing about the pelvic exam is to know what it is, what's being done, and the instruction for the client. Void prior to the exam. In the position. Lithotomy. Okay? So know the position, the client instruction, and what to expect from the exam, right? You're going to be palpated, a speculum can go in the vagina, and possibly, right, lubricated fingers to be able to trap the internal structures and palpate around. Now, I'm going to say this, and usually I do before repro. So, as we continue and advance and talk about all this, repro can sometimes be a bit sensitive of an issue. It can also at points be immaturely funny. So I ask that the laughing stay to a minimum, hopefully. Like if you laugh, it's like, aha, and it's like, stop. That's it. And if you do have questions, because we will cover both, male and female reproductive systems. Now, you probably are more familiar with your reproductive system based on your experience, based on your age, exams, or things that may have happened in your life. And I always tell people, for everything in life, not everybody lives your life. Now, on another note, culturally, as well as just ethnically, for different reasons, some people don't talk about or are open about reproductive organs, sexual intercourse, and everything surrounding it. It's not done. It's taboo. So, if people have questions, I sometimes hear scoffs. And it's like almost like you didn't know that. Like, how do you know that? Okay? Not everybody worked or visited Planned Parenthood before or again. Different business. I've had people work at Planned Parenthood. They were like reviewing a lot of this already because they're familiar. Okay? Some people have never really done that. Okay? So they're not familiar with screenings, what's usual, they've never talked to a doctor, parents are a bit off about it, this is normal. Other people are very verbal, they're very open, took sex ed in college, whatever, right? So based on that, please be respectful of people's questions and their, right, like curiosity. Again, if it's relevant, I'll answer it. If it's not, it's not. But just try to maintain it to what it needs to be. Yes? Okay. So, now that we've covered the pelvic exam, go over to the pap smear, which is on page 426. Still part of chapter 57. You will see that it says Papa Nicolau. See the O and the U are, it's opposite. Pap test smear. It's spelled like this. O. Not U O. Okay? If you're scrolling on the ebook, it tells you the page number, by the way, at the bottom if you notice. So you can just go to page 426, like scroll until you get page 426. Yes. So, Papa Nicolau test, pap test, or smear as they call it. During the public exam, a provider may obtain cervical fluid cells by using a brush or spatula and sends the specimen off for cytology or pathology. This means basically, right, they scrape, we'll say with a tool, the vagina or cervix. This is done to examine the cells, so you should know what's happening, right? Scraping away, or fluids or cells. Okay? The most common types of pap smears are thin prep, conventional, we talked about that fine, co-test, and during this, an HPV test can also be done. HPV is human papilloma virus. HPV. Okay. Now there are different recommended guidelines, but we'll go over a few right now. There's a little table. So the Pap test, what's its purpose? So this is for abnormalities in structure, trauma, right? Abnormalities. The Pap test, why are we scraping this away? What are we trying to detect?
Cancer.
Either things, right? It could be for things like cancer, right? Masses, infection.
HPV.
Okay. The Pap test is used to identify precancerous and cancerous cells of the cervix. HPV test is used to identify an HPV infection, which can lead to cervical cancer. Screening tests offer the best success. So you're looking for cancer, infection, precancer, HPV, I mean an infection. Now, I cannot emphasize this enough. HPV is a huge risk for cancer. If you are or have an infection of HPV, or a person that does, are at an increased, tremendously risk for developing cervical cancer. Okay? So you see how I just did it like this? You should draw like a little star. Like, that's a key point. It's a freebie. They love to ask it. The patient has HPV or is being screened for HPV, the nurse understands that. What is the client at risk for, right? Always. What's at risk? What are HPV people at risk for? Why do you give an HPV vaccine for? Why do you, like, all of that always leads to the fact that if you have HPV, you are more likely to have specifically cervical cancer. But yes, cancer. Okay? I cannot emphasize that point enough. Cervical cancer, HPV. This is why people get their vaccine for HPV. Good so far? All right. Potential contraindications. So who can receive this? Clients who are menstruating, who have a vaginal infection, age greater than 65, and you have very low risk of any of these complications. There's no real point to getting it. Clients who've had a total hysterectomy. Okay. Clients who have had a hysterectomy without removal of the cervix can continue this. So we'll go on to what a hysterectomy is, but a hysterectomy in a sense is, right, they remove the uterus. Now if they have a radical or a total, they can also remove the cervix, and in some cases the upper part of the vagina. So without the cervix, upper part of the vagina, there's really not much to screen for. But if that's still there, we can potentially continue to screen it. Now, another reason why you would continue to screen is if the hysterectomy was due to cancer. If that's the reason why they had it removed, they obviously continue to screen. This is just logical, right? Now, the questions on there, I've seen that. They'll talk about the client has a subpingual oophorectomy, right? Or they've had a hysterectomy. And then they talk about disorders that involve the uterus or the ovaries. How could they possibly have these disorders when they no longer have the organ? Right? Or people are like, what should include, the question they ask is, what indicates a need for further teaching? This means what's wrong, right? So in some cases, if they've had a hysterectomy, the uterus removed, right? Can the client get pregnant? No. Right? So when they say, I can't wait till my surgery is over and later on I'm going to get pregnant, need for further teaching. They're not understanding what's happening. They're saying a statement that does not align with the procedure. So you need to educate them. Make sense? So that's what indicates, right, what's wrong. So a lot of times with these surgical procedures, that's a big thing with it. Client education, schedule the pap smear at least 6 days after their last menstrual cycle. Refrain from using vaginal medications, douching, or having sexual intercourse within the 24 hours prior, so that you need to know. Okay, so you see where it says client education? Those bullet points right there. Refrain, so stop. Vaginal medications, meds, intercourse, douching, "24 hours prior." May experience mild cramping, bleeding, after exam. Mild. So when it says, right, they expected or saw some or a little blood, that's okay. If they describe it as heavy bleeding, right, it's not okay. Large clots, heavy bleeding, saturating pants, less than an hour, that's too much.
Oh.
Okay, now look at the little table for the recommended guidelines. 25 years, you should begin screening. And then 25 to 65, if they have their cervix, they get it every 3 to 5 years. It's usually every 5, but if they're only doing a PAP, they can do it every 3. Right? Primary HPV test every 5 years. If primary HPV isn't available, you can test every 5 or every 3 years. 65 and older, the client has had regular screening the past 10 years with normal results and no history of CIN2. In the past 5 years, they should stop cervical screening. So at 65, if they've never had any indication, with no indicator, just stop screening.
Bless you.
We're almost done with pelvic impact. Just a few more points. We'll write them in red since there's a lot of writing now, right? Pre-procedure. What's the main thing to get? Informed consent. Ooh. This is one of them. Informed consent. Instruct the client to empty the bladder prior to testing. Still applies, so make sure you're aware, it's up there. Empty the bladder, have them pee. Assist the client into lithotomy. We are there, right? Lithotomy. Check. Gather supplies and equipment and ensure adequate lighting. Provide privacy. Don't forget privacy. Now you should really have a keen eye for that, and it's not rude. Face the client, not their visitors, no matter what they think, especially with clients that are of age, right? When I see families there or whatever the case, I let them know what we're gonna do. And I always ask, do you want your family to step outside? Like, do you want privacy? Because sometimes I think they don't want to tell them, right? But I'm like, we're gonna change you. Do you want some privacy? And you're trying to step outside, and so they're like, right? And I tell them, like, step outside, please, right? But because they probably just don't have that boundary. So always ask the client if they want privacy, no matter who's there. Good. Intra-procedure, there's not much that we do. Basically, I help the doctor. Post-procedure, it emphasizes again, provide the client with perineal pads and tissues. There's a little bit of potential bleeding after the procedure, right? Again, a little or some bleeding, that's okay. That's expected after the procedure, it can happen. Okay. Common questions revolving around pap smears, pelvic exams. 1, positioning. It's gonna be as simple as that. 2, like the purpose, like what are they looking for, right? It doesn't be so specific, but just a general idea. Instructions for before, right? What should the nurse tell the client to do prior, right? Or what should you check for first? Informed consent. The other one is the client received the pap smear or pelvic exam, right? And what should they expect when they go home, or what should you teach them? What should you teach the clients? And that's the post instructions, right? Make sure you monitor the bleeding, or the one they're preparing for a pelvic exam. What do you do, right? Make sure they empty their bladder. So things like that. Make sure that they don't douche, no sexual intercourse, and what's that one? No vaginal meds. Okay? So that's for the prep. So those are the types of questions that will come up. Any questions so far? All right. Next one. Just get this together, but anyway. Next one. If let's go to page 428. At the bottom of 428, you'll see that it says colposcopy. You'll see colposcopy and cervical biopsy. Name of the procedure.
Keep on going.
Now, if your pelvic exam and more than anything, your pap smear are normal, then they're normal. That's it, right? You're fine. But if they are abnormal, the next step is this. So if you are asked, the patient, right, received the pap smear, showed abnormal cells or a normal result, what do you anticipate, or what should the nurse anticipate, right? What's the next probable step? What can happen? What's the follow-up? Colposcopy with cervical biopsy. So it says here, right, a colposcopy is an examination of the cervix, vagina, vulva, and anus using a colposcope. Allows for direct examination of unexpected lesions. In a colposcopy, the provider can perform an endocervical curative, scraping of the endometrial tissue, or cervical biopsy. The best time to perform the biopsy procedure is in the early phase of the menstrual cycle, because the cervix is less vascular. Now, indications of pap tests with atypical or unexpected findings, like HPV or dysplasia. So why do we do this? Abnormal pap results. This warrants further investigation. And the action here again is and scraping and biopsying. That is to be of the endometrium, which is part of the uterus, right? Cervix, vagina, the external, right? The vulva. Okay. During this colposcopy and cervical biopsy, they can perform something called a cone biopsy. You can think of this like if this is the tissue cell, right? So you put it out. They remove, if there's any malignant cells, right? They want to do a cone big enough that can like remove hopefully everything. And again, it's examined, hopefully can get rid of any malignant cells. They can do a cone biopsy, but that's less. Anesthesia is used at this point to remove such a piece of tissue. Now, client education, very similar to the path. Instruct clients not to douche, right? Sex, vaginal meds. Four to 48 hours before. It's under client education. If a biopsy is performed, there could be minor discomfort, cramping, temporary, expected. Rest for the first 24 hours after the procedure. Abstain from sexual intercourse. No insertion of items into the vagina like the douche, vaginal cream, or tampons until confirmation of healing, approximately 2 weeks. So, no sex, tampons, vaginal meds, items in general. Okay, for 2 weeks after the procedure. Avoid lifting heavy objects for approximately 2 weeks. So you can add to this. No heavy lifting. Report excessive bleeding, fever, foul smelling, drainage, right, and or drainage. To the provider. Fever. Fever. So again, the questions. So you guys get in the habit of this, right? The